We're at IAS 2018 in Amsterdam. We're here with Alan Landay from Rush University. And we always talk to you about how people living with HIV are dealing with the challenges of side effects and so forth. And I'm going to let you just kind of bring up some of the things that you covered at the conference or you saw at the conference that are important to know about.
Well, I think we're learning a lot more about the idea of the non-communicable diseases. We're seeing our HIV populations are aging. They're living longer with the current anti-HIV medication. So now people, and I saw some interesting statistics at this meeting that, somebody infected today at age 20 will live almost a normal lifespan up until 75 or 80. So it's a tremendous advancement in our abilities to enhance the patient's longevities. But we're still, and the older they get, we're going to be seeing now the disease of aging. So it's great news on one hand, but there's still the HIV infection does leave a residual immune inflammation and may lead to what we're now calling inflammaging. So we're going to be seeing now, and what our physicians all over the world are going to see, are those diseases of aging, cardiovascular disease, metabolic complications, neurocognitive, and cancer. And we heard a lot about all of those diseases here at this meeting. A lot of new studies trying to link measures of aging. And what we're finding is that we need to cross our disciplines and work with folks who take care of our older patients now, our geriatricians. And we need to start thinking about how do infectious disease physicians who have taken care of our HIV population actually start to talk and link with geriatrics medicine and think about those. There are areas, what is known as frailty measurements that have been done, and these measurements are done routinely in the Office of Geriatricians. There are things like chair stands, walk speed, or grip strength, and these all come together to define frailty measurements and how do people feel and how well and how mobile they are. And we're now going to recognize that these are going to be the effects we're going to be seeing on our HIV populations. One of the other things I heard from a plenary session by Emily Heil on Thursday was the idea of syndemics. So this is a term many of the audience may not have heard about. These are when multiple epidemics converge on each other. And now what we're seeing in our international settings, especially being here at an international AIDS meeting, are the epidemics of HIV, tuberculosis, and diabetes coming together as a triad. And we're now seeing in that triad the impact of the economics of the countries that people live in, and also aspects of food insecurity. So all of these are going to be underlying aspects that will affect the outcomes related to HIV infection, TB, and diabetes. And both of those diseases, both HIV and TB, will contribute to the development of diabetes within the aging population as well. So we're now recognizing a lot of these interactions, and they're not just anymore in the developed world, but we're also dealing with these in the developing world as well.
The one thing that you were saying earlier is that we're having to look at these things, that people that are infected and now are getting older. There's a difference between the people that are being infected more recently and those who were infected and have lived through god-awful antivirals, terrible things, that comorbidities of sorts, that when we were able to not control the virus as much as we wanted to. And current, where they just got recently infected and they're determined that they're infected very quickly. They're discovered very quickly, differently than in the old days. We had nothing to do for people. They basically just abided time until the drugs came out. So those that were beat up by the drugs, so to speak, in the old days are a different population, I think.
Absolutely, and those people started later, when their CD4 counts were below 300 or even 200, and their levels of inflammation and the impact of that persistent dysregulation of the immune system is going to have an impact today even greater than somebody who starts in 2018 with the current drug regimens. And as you pointed out, the drug regimens themselves, the protease inhibitors, the nucleoside, the reverse transcriptase inhibitors, all have had impact on the immune system and on metabolic complications. So all of these are going to contribute now as those people who were infected back in the 80s and 90s are reaching 2018 in their 50s and 60s. They're going to have a more significant impact on their disease of aging because of all the other exposures to the drugs and the significant effects on the immune system as well, where it was much lower in their CD4 count when they started.
I think the thing that people living with AIDS really care about is how they feel and what they can do. You know, can they be productive in the way that they want to be productive? And I know that's probably one of the first things I heard when I was at support groups way back, many hundreds of years ago, it feels like. But people would say, I can't play the piano, or I can't think. I can't, you know, the cognitive dysfunction, it was like dementia. And I mean, lots of horrible stuff in the old days. But today it seems like there's still those issues, but they're not as prevalent. It seems like people are able to navigate. The drugs, I think, contributed to a lot of that themselves, but the disease itself, being unchecked, did allow a lot of things that we would prefer not to have happen.
Yeah, I think that's absolutely true, and I think we're going to be seeing people, and what we're dealing with are the other sort of normal comorbidities that we think about in a general population: smoking, diet, alcohol use, drug use.
These are controllable.
And these are all controllable factors. These are things that if the patient may be feeling bad, then get out and exercise, get out and do something. We're recognizing the significant impact exercise can have on inflammation. And a lot of that persistent inflammation in HIV can be impacted by exercise and just getting up and walking and being mobile, and if you can, and just participating and not just sitting back. We realize too that there are significant impacts on mental health issues and some of the isolationism people might feel, or stigma that there might be felt also in being HIV infected. It still exists all over the world, and I think this meeting has highlighted for us the stigma of HIV still exists in 2018, and that does affect, interestingly enough, the immune system. There are, through the hormones and the cytokines in the body, when you have stigma or affected by that, you can increase those levels, and they will have untoward effects. So I think it does pay to, in terms of healthy living and thinking more about exercise and maybe just eating a little bit better. That's all going to, don't go to McDonald's this week, have something like a healthy salad instead. And I think we all feel that way, that we'll do better.
I think it bears reinforcing that message and saying to the audience that if you're a person who is living with AIDS and who is isolated, don't be isolated. Find a way to twist that around. And if you're a person who's not living with AIDS but knows someone, a family member, a friend, somebody that's in a support group, drag their butts out of the house. Take them somewhere. Get them to walk on the beach, walk on the mountain. Regular activity is so critical. It becomes almost essential when you're older, because if you go into a wheelchair on a permanent basis and you don't have any way to mobilize your body, it really is challenging. It's a slippery slope.
Absolutely, and I think it's not only important for your physical health, but your mental health. When you get out with people, you get out in the community,
clear your head.
You can really see an improvement. And all that's going to help you deal better with any of these diseases of aging that we're thinking about, because that'll help reduce what we know is contributing to some of the comorbidities and help to improve. And I think everybody's going to feel a lot better. We're going to do a lot better for our patients.
And another thing, I know you've been attending over the years, there's the Comorbidities Conference, we call it, and also the Aging Conference, both of which have done focus on largely what we've been talking about here, and have brought to the surface the issues that are really critical to making people feel well. And I think it's my hat's off to the people that keep that going, because it really is a critical piece of evidence that needs to be proliferated. And we do what we can. We go to those meetings, we talk with people like yourself and about what was presented, and the data is there. They're now, not only do we know, empirically that it is what we say it is here, but there's data that's supporting it. We have the walking study and the gait study. I mean, there's things that prove these messages out. Certainly the smoking, those are all been covered already.
Yeah, and there are many of those presentations at this meeting today here in Amsterdam that are really highlighting how we can improve health of our patients and those folks out there living in the community with HIV. And I think it is critical to engage in support groups in your own community and really get out there and do things and show that you can be mobile, you can be active, and that's all going to help going forward.
It's a hard road sometimes to get the first movement going, but once you do it, kind of snowballs, I think. So take the step, just do it, as they say.
Yeah, just do it. Just take the Nike adage, just do it. I think, this meeting also is teaching us a lot more on some other areas that we're going to know. And as we're thinking about, I know you've talked about the cure, and some of the things are, as we're thinking about new strategies for cure, those are also going to be applied in patients who are getting older, because around the world the patients are getting into their 50s and 60s. So I think to have effectiveness, and we heard this at the conference this week, in order for new cure strategies to work, we have to have the inflammation reduced in the patients. And so that's a part of aging, and that's a part of what the virus has done to the immune system. So we may be looking at other opportunities. We know we have a large trial on statins to look at their effects on cardiovascular disease from the immune perspective. We also look at aspirin effects. So I think a lot of these other approaches, we'll hopefully validate those as ways of reducing inflammation. Once we do that, we'll have important effects on these things like cardiovascular disease and metabolic disease, but they will also be critical as individuals are being asked to participate in studies of cure research, because then there'll be a greater chance of them responding to those the vaccines or other approaches if they no longer have that persistent immune inflammation.
If the immune system is a little under control, they're going to have a better course.
They're going to have a better course and a better response to all of their therapies and health.
Well, thank you very much, Alan. I appreciate it, and I look forward to the next visit because we do it regularly.
Yes, we do.
And I do want to thank you for the work you've been doing all along and supporting the community in the way you have. It's been very helpful.
Great. Well, thank you, Fred. I appreciate it, and happy to do this.